Hello, today we're going to talk a little bit about the postoperative shoulder, which I see a lot in my everyday work at the orthopedic clinic. And I think we'll get right to it, starting with the most commonly referred patient to an orthopedic clinic postoperatively, which is the rotator cuff suture patient. And usually they are referred either that it's not going as rapidly as one had hoped for after the surgery, or something has occurred later on, a new trauma, or that the patient has become worse in his symptoms sometime after the rotator cuff surgery. And we're talking about the rotator cuff, so the structures that we are assessing are of course the same as in the patient that has not underwent surgery. So if we look a little bit on this image that we have in front of us, this is a torn rotator cuff. So this is the pre-op picture and this is the post-op picture of the same patient. And we can just start by commenting that this is the actual retracted tendon. This is the stump of the supraspinatus tendon, and this is just a little bit of thickened bursa. So thickened bursa, tendon, thickened bursa, real tendon tissue. So the retraction rate is from here to there. This is the footprint on the greater tubercle. So when we look at the structure post-op, we look for the hole for the anchor, where the anchor has been attached to the bone. You can usually see that. If you don't see the contour of the anchor, you see the hole where the anchor has been screwed down. So when you see that point, you're going to look medial to that and see that you have tendon tissue immediately to the medial of the anchor place. And within this tendon tissue, we can in this case see the hyperechoic suture. So this is a long axis view of the supraspinatus and a long axis view of the suture. So this is a case of a successful rotator cuff suture. And what we also should comment on this subject is that of course it's ideal if you have the actual surgical report, but no matter what, it's important to know that sometimes the anchor placement is not on the exact anatomical place where the tendon used to insert. Sometimes for one reason or another the shoulder surgeon may need to place the suture anchor more medially, more towards the cartilage. So that is something to be aware of, because if we look at this sonographically afterwards, it may look like this, that the anchor placement is a little bit more medial. So here we have the hole for the anchor, and we can see directly medial to this that we have tendon tissue, and also we can see the actual suture here, this hyperechoic line. But since the anchor is placed more medially, we will have a bare area here, which is hypoechoic. So this is what we usually look at when we say that we have a rotator cuff tear. So we have the bone, and above that the empty black void. That is usually what a tear looks like. But now we need to be aware of that we have the anchor placement here, tendon medial to that. So this is the new insertion of the tendon, and this is just how it turned out after the surgery, and not a re-tear. So that's very important to take into consideration when you examine the post-op rotator cuff patient. So these are three examples of placement of anchors sonographically. This is what we looked at just in the prior slide, medial placement, and this is somewhere in the middle of the footprint, and this is all the way out laterally to the footprint, so more of the anatomical insertion that we're used to see in the non-operative patient. So be aware of that. And we have talked and looked a little bit on the sutures in long axis. So this is hyperechoic line, long axis view of supraspinatus tendon and the suture. But if we look at this in the short axis view, the sutures are just small hyperechoic dots. So the short axis view of the actual sutures within the tendon looks like that. And if we should say something also about the morphology, the appearance of the suture tendon, especially over time. In the beginning, this is quite some time after the surgery, so this is the healthy side and this is the sutured side. What we can see immediately when we look at these pictures in front of us, we can see that if we look at first at the healthy tendon, we can see this is the bursa, this is the real tendon up to here, and then we have the bursa above that. And here we have the actual tendon tissue up to here, and then this is bursal tissue, and you can see that this is thickened, much thicker than on the non-operated side. And this is usually the case, that actually this thickened bursal tissue stays over time. So even if it's 1 year, 2 years afterwards, usually you have a thickened bursa. And that can of course make it more tricky for us when we assess if the question is there a retier? If you have the thickened bursal tissue, that if the tendon retears, the thickened bursa will take the place of the tendon and look a lot like tendon. So be aware of that you can have tendon-looking tissue in the same area. So you have to look in different positions, different angles, and also compare a lot to the healthy side and see actually what is real tendon tissue and what is bursal tissue. So that is one point, and the other is that usually in the beginning, this is, as I said, quite some time after the surgery, but in the beginning the sutured tendon is a little bit thicker, it's more hypoechoic, and it also usually contains some areas that are almost anechoic, so little tears that over time fills up and the tendon becomes more normal looking, and the fibril pattern also restores over time, and that is what usually happens. This is another example. Maybe the difference is not that huge, but if we look at 3 weeks, here is the anchor placement, suture, suture. That 3 weeks here we have more of these little black holes within the tendon, still some defects, and the fibril pattern is not as nice as 3 weeks later. So 3 weeks later all of the tissues are kind of more smooth, and the fibril pattern and the echogenicity is more normal looking. That is what has happened during the 3 weeks, and that will of course even after 6 weeks improve a lot. 6 weeks is short after a rotator cuff surgery. And of course the main thing that we are looking for in this patient group is retiers, and this is what a retier looks like. We can see in short axis where the anchor has been placed, we can see in long axis where the anchor has been placed, and this is just this thin line is just bursal tissue and debris, so there's no real tendon tissue here. So we'll look at the anchor placement, we'll look directly medial to that. Can we see some tendon looking tissue? Can we see some sutures? And in this case we can't, and also just a naked head in the short axis view. This is just another example of that, long axis view of a sutured supraspinatus, and in this case maybe it's a little bit more of thickened bursa and debris. So if you're not experienced, you might lean towards saying, okay, we have a thin tendon that has not gained any height yet. This is something that I read quite frequently, and think that's maybe a result of lack of experience looking at patients after rotator cuff surgery, but maybe also a little bit of wishful thinking, because it's always hard to tell the patient that sorry, this surgery was not successful, the tendon has retorn again. So here we have the kind of a big hole where the anchor has been placed, but medial to that only bursal tissue. And of course we want to look at this patient in the short axis view, and that is what it looks like in short axis. We can see the placement of the anchor, and above that no real tendon tissue, just bursal tissue. And that becomes even more clear if we compare it to the other side, where we have real tendon tissue and then bursa. Here we just have one layer of thickened bursal tissue. And this is actually the same patient as in the slides before. So this was a big tear, a very wide tear. So we can see it also in the posterior view where we look at the infraspinatus. We can see the suture or the anchor placement here. And then we can see just an empty void until here, where we have the retracted stump of the infraspinatus, which is also hyperechoic and atrophied and fatty infiltrated. And this is compared to the healthy side, where we have a thick muscle belly of the infraspinatus, and here just a hyperechoic looking stump. Yeah, this was some explanation and images. Yeah, and this is just a phenomenon, maybe not the best of pictures, but this is a long axis view of a sutured supraspinatus tendon, and we can see this is the outline of the supraspinatus in long axis. And you can see here this hyperechoic line, which is the sutures, and where the suture ends, it's just a black void. So this is what we call free-floating sutures, so they have no real attachment to real tendon tissue. So this is also a Retier quite recently. So you have a big swelling, and maybe you have some debris of tendon here, but where the tendon ends, there's no real, where the suture ends, there's no real tendon tissue. And let's say something also about the anchors. The anchors should never stick up from above the cortical line, so they should be buried down in the bone. They should not stick up above this line, not on the X-ray, and of course not on the ultrasound either. So this is the anterior facet of the greater tubercle, posterior facet, and here is the hole for the anchor, and we can't see the actual anchor, but what we can see is tendon tissue directly above it, so it's a successful suture. Same thing in the long axis view, where we have the anchor placement, nice looking tight tendon tissue directly medial to that, so nice outcome sonographically after the rotator cuff surgery. And nowadays, when I first started with ultrasound, there were mainly metal anchors that were visible on X-ray. Nowadays there is mostly bioresorbable anchors or plastic anchors, or even no anchors at all, what is called all suture anchors. So you place the sutures within the bone, and then they expand once they're in place. So the result of that is that you nowadays usually cannot see the anchors on plain X-ray, so maybe that's even a bigger place for us sonographers because of that phenomenon. But important to know when you work with imaging of the post-op shoulder. So this is a situation where we have a backed anchor. We said before that the anchor should not stick up above the cortical line, and here it's clearly above the bone line. And same thing here on the ultrasound. And what other information we get from the ultrasound is that we see the backed anchor, and medial to that just a herniation sign. So the suture and the supraspinatus tendon has retorn. So this was an elderly osteoporotic lady, so the osteoporosis is the reason that the anchor backed out. And backed anchors are very uncommon, I would say. Retier is very common, but backed anchors very uncommon. And this is a situation where an anchor has detached, and this is not a metal anchor, so we can't see it on X-ray. And the anchor had been placed over here, and then got loose from the bone and rotated and ended up here just beneath the deltoid. And if we look carefully now in hindsight, when we have the sonographic image, we can actually, if we look carefully, see the anchor on X-ray, even though it isn't a metal anchor. So if you know where it is, usually you can see it vaguely on the X-ray as well. So to sum up the rotator cuff suture, you try to find the hole for the anchor and look medial to that for tendon tissue. Be aware of the thickened bursa so you don't mistake that for tendon tissue, and anchors should not be seen above the bone, so on ultrasound we shouldn't see them, we should just see the hole where it has been drilled and screwed down. And the usual retier is usually very big and wide with far retraction, so we should not look for small defects. That is maybe the result after the surgery. Yeah. So let's move on to the next or another big group within the post-op image assessment, and that is the shoulder replacement patients. And we talk now about the anatomical shoulder replacement where the rotator cuff is intact, so that it's quite usual that we get referrals for that it has been a good result, and then after a few years or after trauma the patient gets new or worse symptoms, and the question usually is, has something happened with the rotator cuff? So looking at the rotator cuff or the shoulder replacement during the surgery, the supra and infraspinatus remains intact. It's nothing done with them during the surgery. So in this case we look at, in a long axis view, of the supraspinatus tendon. We have the acromion here and the supraspinatus tendon that has its old attachment to the footprint on the greater tubercle, and then beneath, instead of a real humeral head, we have a metal humeral head, the prosthesis. And as I said, also the infraspinatus is intact, has its old attachment, and beneath it we have the prosthesis. So this is what it looks like if we should do an external rotation. We see the infraspinatus doing the external rotation, and beneath the infra we have the prosthesis. If we look on the front of the shoulder, the subscap is detached from its insertion during the surgery, so the shoulder surgeon can fit in the stem and the prosthesis. And then once that is done, they reattach the subscap, so they have actually done a Scapularis suture. So if we look at that sonographically here, we can see the footprint and insertion of the subscap, and then medial to that we see a new metal prosthetic head. So that's what it looks like with some colors and explanation. And if, of course, again, the usual question for the referred patient is, has something happened with the rotator cuff? And this is what a subscapularis tear looks like. Here we have the prosthetic head, but not as in the prior image. We don't have any tendon coming from this side, just the deltoid, and then just beneath that we have the prosthetic head. So a totally torn subscap, and we do some internal and external rotation and see that we have no subscap, no attachment there, and no tendon in this area. So that's the coracoid process. Another example of this, we have the long axis view coracoid process. We have a black void where we usually see the subscap, so prosthetic head, black fluid filled void, and this is the short axis view, proximal, distal, and prosthetic head, black void. So the principles are the same as when you examine the rotator cuff in the non-operated patient, but some features differ. Yeah, this was the same patient as before, and some external internal rotation, coracoid process, prosthetic head, and above that just a black void. Yet another example of a subscap tear. So I would say that since the subscap is resutured, this is the weak spot after shoulder replacement, and usually the patient's symptoms are, many can complain of a little bit of anterior instability and pain on the anterior side, but usually that when the subscap disappears, you get a little bit of anterior translation of the humeral head and some form of instability. And of course, you can get ruptures in the other tendons as well. This is a supraspinatus tendon. We have the prosthetic head down here, and this is the anterior part of the supraspinatus. The biceps tendon is down here. So here we have a black void that is communicating up from the bursal tissue down to the prosthetic head, so a full thickness tear of the anterior supraspinatus tendon. And this is the same patient in the long axis view of the supraspinatus. A black void where we expect to see supraspinatus tendon tissue. So here is the prosthetic head, the footprint on the greater tubercle, and the tear of the supraspinatus. So tears of the rotator cuff is the most commonly addressed problem and question when you do sonography of the shoulder replacement as well. So this is a little bit of a summary of common post-op patients within the orthopedic field. So thank you for watching, and if you're interested in going even more into detail about shoulder sonography and even more cases post-op, we have courses in the Nordic countries this fall. So you are more than welcome to come to Gothenburg or Copenhagen in September, or Stockholm in December. And more information is on the website where you find the address here. So there you have all the information, and I hope to see you in Sweden or Denmark after the summer. Again, thanks for watching.